Okay, thank you, Raj, and hello, everyone. What I'm going to talk about this morning is a body of work which is joint with my colleague Apostolos Davilas, who is now at the University of East Anglia. And this is based on a number of published papers, some of which are listed on the very last slide here. So if you want to look at the details of this work, that's where you can find them. Just to set the scene, in August 2019, which is just a few months before the world turned upside down, the Secretary of State for Health and Social Care announced a review of the NHS Health Check. The NHS Health Check has been described as a kind of medical MOT, which is offered every 5 years to everyone in the age range 40 to 74. And the aim is to try to promote good health amongst this population. At the time of the announcement of the review, the Public Health Minister, Joe Churchill, stated that the aim was to build, and I quote, a preventative, personalised and predictive health and care service. And the emphasis here is on predictive. And our work fits rather neatly into this view of policy, which is driven by something you could call predictive analytics. Our work predated that review of the NHS Health Check, but nevertheless, it's very much in the same spirit as that review is supposed to be undertaken in. Let's start with the analytical approach that we've used. We're using the Understanding Society panel, or UKHLS, which is a long-term, longitudinal survey with annual interviewing. And the remarkable thing about it, from our point of view, is that in wave 2, a whole bunch of nurse-conducted interviews were carried out, and those nurses measured various health-related aspects of the individuals and took blood samples. Now, we have focused in this body of research on people who appear to be healthy as far as the NHS would be concerned. So we're looking at kind of latent health problems rather than problems which are already known about. So what we did at wave 2 at baseline, we selected people who had declared no diagnosed significant health conditions, no significant disability, and who reported taking no major medications, no medications for major illnesses. So we're looking at the set of people who, as far as the health system are concerned, appear to be okay. The biomarkers and biometrics that we look at include a very wide range of different indicators. These are nurse-measured biometrics relating to adiposity, so this is things like waist measurement, weight, and so on, heart rate, blood pressure, but also things like grip strength, which is an indicator of general condition, lung function measured by spirometry. And the blood samples that the nurses took have been used to analyze a whole range of markers of health conditions. So these markers include things like cholesterol, blood sugar, etc., covering a range of biological pathways in the body. So all of that happens at wave 2. Then 5 years later, at wave 7, we look at a number of outcomes. And the outcomes are measures of health service utilization. So this is the number of consultations with a GP, the number of hospital outpatient consultations, and the number of days spent as an inpatient in hospital. And this is within a 1-month recall period. within a 1 year recall period. A second outcome that we're interested in this work is some sort of estimates of the cost of that service utilization. And we can look at this using NHS indicative cost figures. And a third outcome that we're interested in is disability. And this is because disability is obviously closely related to the concept of health, and it's certainly strongly related to costs, both of health and social care. Now, we're in the business of prediction, so we're working from baseline at wave 2 to outcomes 5 years later. And we're interested particularly in using biomarkers, biometrics as predictors of these later outcomes, alongside personal characteristics like age, gender, education, income, and so on. Now, these biomarkers are typically designed to be indicators of specific biological pathways. For example, the level of albumin in the blood is an indicator of the state of the liver function. Or spirometry can be used to measure lung function, the power of the lungs to incorporate oxygen into the body. So, now these biomarkers are intended to be quite specific to particular pathways, but in practice, they're actually much more general as predictors. And this is because impairment in one biological pathway often coexists with impairments in others. So although markers are designed to be quite specific indicators, they actually turn out to be quite powerful wide-scope predictors of general health. The other thing about these biomarkers is that they are just markers. They're not direct observations on the health state of the individual. And these markers have a certain amount of measurement noise in them. They have an element of randomness there. And that needs bearing in mind when using these things as predictors. Now, we use combinations of quite large collections of biomarkers rather than individual biomarkers. We do this either by combining the biomarkers into indexes, and a sort of general biomarker index is often known as allostatic load, which is intended to be a measure of the cumulative wear and tear on the body, if you like. So the first and third of the papers referred to at the end use this method of first combining the biomarkers into an index and then using that index. An alternative approach is to use the data to try to construct the best predictive combination of biomarkers. And this can be done using latent variable modeling. And that takes account of the sort of randomness in these markers as well. And the second paper listed at the end of the slides is an example of the use of that. I'll very briefly go through the general findings that this work has led to. I'm not going to go into the details at all because we don't have a great deal of time, and we're really concerned with the way this sort of research might be used rather than the details of the research itself. I'll look at the findings in three aspects. The first is service utilization, the second is the cost of that service delivery, and the third is the role of disability. So for service utilization, we have basically three categories. The first is the number of GP consultations within a 1 year recall period. Second is the number of hospital outpatient consultations in that same recall period. And the third is the number of inpatient days, days spent in hospital during that same period. And the recall period is the 12 months leading up to the interview at wave 7, where these things are reported. We use statistical models specifically designed for handling utilization counts. So this is a count of the number of consultations or the number of days. And these models are predictive given allostatic load and personal characteristics. These are the predictors we use. Allostatic load turns out to be a highly statistically significant predictor in addition to the personal characteristics that we're using. And rather than go through a bunch of sort of statistical model estimates, I'll just give you a little back of the envelope calculation to indicate just how large these impacts are. So suppose we take a set of high-risk individuals. So these are people with allostatic load more than 1 standard deviation above the mean when measured at baseline. And that's roughly the worst 16% of people in terms of their allostatic load index. Suppose we were able at baseline notionally to cut each of their baseline allostatic load levels by 1 standard deviation. So we somehow magically could have made them that much healthier at baseline. So this is not a simulation, it's just a calculation to indicate the magnitude of the impact that the statistical modeling implies. If this improvement in the health of this group of apparently particularly unhealthy people could have been achieved, then the number of GP consultations would have been reduced by 19%. The number of hospital outpatient consultations would have been reduced by 12%, and the number of inpatient days would have been reduced by 44%. And these are large effects. In terms of costs, we can't use linked UKHLS HES data. So we're not able to link Understanding Society to hospital episodes records from the NHS because this linking hasn't yet been achieved for the survey. Instead, what we do is use data combination methods. So we have some external estimates of the average costs within each sort of treatment condition category in the NHS. So if we look at inpatient reference costs, the data published by the NHS gives you a mean cost for each of something like 3,800 treatment condition categories. Now, we don't observe in Understanding Society what the condition was actually that the person was in hospital for, but we do know the length of stay. And we also know the age and the gender of the individual. And we do also have some information in the NHS cost data on the distribution of the length of stay and the age and gender breakdown for each of these 3,800 categories of treatment and condition. And that means we can estimate an expected cost for each individual in Understanding Society, conditional on their age, gender, and the length of inpatient stay that they've declared at wave 7. Now, obviously, a lot of assumptions have to go into this. There's some uncertainty about the estimation, but nevertheless, it's a reasonable basis for trying to make these projections. And note that it does have the advantage that we don't have to ask the consent of any Understanding Society participant because we're not actually linking an individual to any particular NHS records. Again, we get these big impacts. So if we could take these 16% of the sample who are most unhealthy and sort of magically make them healthier, then the reduction in total cost of GP outpatient and inpatient would be almost 20%. And the magnitude of that impact is approximately comparable to the effects you would have if you could somehow reduce the age of the 45 to 74 age group by 10 years. So this is a major effect, which is equivalent to quite a big change in age. Finally, we have the role of disability, and this is a separate study which is looking at service use and also disability as outcomes, joint outcomes of wave 7. Here, what we're trying to do is to look at how disability is involved in these costly outcomes 5 years after baseline. And what we find, just to emphasize it with something that I think is really well understood already, that disability is an extremely important part of the whole cost picture. It really doesn't make sense to talk about medical aspects of health and disability as separate things. These are so closely related. So if we look at the expected costs of people who 5 years later have no disability in the outcome, and compare that with people who declare some disability at that stage, we have something like 3 times the risk of a high level of cost for those outcomes. So disability is really involved in the generation of these high treatment costs. And lastly, in this same piece of work, rather than using an index like allostatic load, what we've tried to do here is to use the data to tell us which of the biomarkers involved is actually most sensitive to the underlying ill health. And this table shows you a kind of league table of biomarkers in terms of their sensitivity as indicators of the latent health problem, which is generating these adverse outcomes. Now, the NHS health check, which I mentioned at the beginning, relies on biomarkers for adiposity, that's BMI, in fact, blood pressure, cholesterol, and blood sugar. If you look at these things, they are, in fact, towards the bottom of the league table here. The most sensitive indicators of the sort of latent ill health, which is generating the costly outcomes 5 years later, turn out to be lung function, grip strength, hemoglobin, and so on. And this sort of gives the message that the very wide range of biomarkers we use might be very valuable as a screening tool, possibly even more valuable than the measures which are being used at the moment in the NHS health check. Note that this doesn't imply that things like cholesterol, hypertension, and so on have no predictive power. It's just that when we use these things all together, given that they're all highly intercorrelated, other things actually may be more effective in terms of prediction. Now, trying to build a bridge between this sort of work and policy is quite challenging, and I would emphasize this caution at the bottom of this slide. There really is an enormous gulf between just demonstrating predictive power, as I think we've done, and designing some sort of practical policy to exploit it. But nevertheless, biomarkers do look like a promising way forward. First of all, they are more objective than self-reported health. And we know this is a problem. We know that some patients, for example, exhibit behavior which is directed at achieving some desired treatment ends. For example, we know about pressure on GPs to prescribe antibiotics. So if measurement is going to be explicitly linked to some kind of interventions to promote better health, then self-reported markers are more open to manipulation. And there's some advantage to biomarkers which are, in a sense, more objective and less easily controllable by patients. These biomarkers, I think we've shown, have very strong predictive power, additional to the usual demographic and socioeconomic characteristics. And the question is whether these things can be exploited for policy purposes. A lot depends on what kind of policy we're talking about. The obvious area here is individual level policy. So we could, for example, look at the NHS health check and try to use a wider range of biomarkers, possibly different biomarkers, to improve the efficiency of the health check. Now, there has been a lively debate about the cost effectiveness of the NHS health check, and cost effectiveness is the big issue here. To demonstrate cost effectiveness, we would need to demonstrate that the improvement in predictive power that we think we found is actually large enough. We would need to demonstrate that the additional testing costs of actually producing all this wider range of biomarkers are low enough. And critically, we would need to somehow achieve adequate take-up particularly by people whose biomarker levels are poor. These tend to be people in disadvantaged areas where take-up of the NHS health check is already relatively low. And of course, the health check only provides information to individuals, and that information is only of value if there are effective interventions, either by the individuals themselves or by externally, which will achieve health improvements. And there is a question mark over that. One thing I would emphasize, given the role of disability that we have found, is that interventions that prevent poor health state developing into disability are particularly important, though it's not at this stage clear what those interventions would be. I will stop now, but just make one final point. In a third paper, we have looked at couples' health. In other words, we've analysed married or cohabiting partners and looked at the correlation between their health states as revealed by biomarkers. Now, those health states are very highly correlated, and they're highly correlated for two reasons. One is because of assortative mating, because people who are similar in some respects tend to marry each other. But they're also correlated because of shared health influences during the course of the marriage. But the correlation suggests a possibility of family-based rather than individual-based interventions and screening programs. So what we find essentially is that the health of one partner is actually quite a good predictor of the health state of the other partner. And this raises intriguing questions about whether there could be within the family triggering of interventions designed to promote health. But of course, it raises enormous ethical issues because it's not clear that it's going to be acceptable to use one partner's biomarkers, for example, to trigger monitoring or intervention for the other partner. There are interesting ethical issues here, but nevertheless, this is an example of the sort of predictive power that could possibly be exploited by this kind of policy. There are various other policy issues which are listed on these slides, but because time is short, I'll stop there.